Hello, I'm Roger DeLong. I'm the Surgical Product Manager and Perfusionist here at Transcranial, and we're talking today about clotting in the oxygenator during ECMO cases. When we first begin with school, we learn about the clotting cascade, intrinsic, extrinsic, common pathways, everything about the clotting cascade. On top of that, we get the effects of anticoagulants and how they affect the cascade at different points. Then we learn about the propagation phases, the initiation phase, all the phases of clotting. Once we're in clinical practice, we learn about the different clotting assays, from the ACT, the ACT-LRs for the low molecular range heparin, APTTs modified from PTs, antifactor 10A, the thromboelastographs, rotational thromboelastometry, both of which are still being debated, antithrombin levels, fibrinogen levels, and lately D-dimers, which are very good at showing fragments of fibrin in the bloodstream. The problem we have in ECMO is that we're under anticoagulating the patients. On the heparinization curve, you can see how the effectiveness grows as the ACT does, and over 95% of patients are fully anticoagulated at an ACT of 300 seconds. And with safety factors of 33% to 60%, that's where we come up with a full bypass minimums of 400 and 480 seconds. But in the ECMO world, we're living in the 180 to 200 seconds, which virtually guarantees that all of the patients are going to be clotting. The second problem we have is the clot formation rates vary. Some of these clots will grow instantly and rapidly. Some will take a longer amount of time. There is some commonality in that as the clot gets thicker and heavier, it'll accelerate. But beyond that, the rate is completely individualized. The clot can only also be seen very near the surface of the oxygenator. There's a clear plate in the front and back, upstream and downstream. And you can see some clot, if there's a different color on one side or the other, maybe, but not always. And as we said before, there's no reliable assay for clot volume. So with all these in mind, how can we ever really know how to change out an oxygenator? Well, let's take a look at the things we do know. The first one is a flashlight test. Everyone's done this. You aim an oblique light at the oxygenator in a darkened area, and you might see a few small specks. You might see something large if it's a matured clot with different colorization. Here you can see there's 5 different tiny specks. They may or may not be stable. They might be gone the next time you look at them. But again, we don't know how much more there is behind the front. Secondly, coagulation testing. We all test every hour, 4 hours, 6 hours, whatever, and we use all the tools that we've talked about before with the ACT, the PT, et cetera, et cetera, et cetera. None of these, again, will indicate the volume. The universal thing everybody uses is the pressure differential. By this, I mean the pre and post oxygenation levels. They assume that the oxygenator clot is going to appear like this, where it grows smoothly and evenly across the face of the oxygenator. Then you'd have a linear response between the amount of clot and the building of pressure upstream from the oxygenator. But that's not normally the way it goes. Looking at the quadrox oxygenator, which is by far and away the most commonly used, flow is going to be slowest in the corners, and not surprisingly, that's where the clot's going to begin to start. Here we can see clot starting in the corners. We can also see one area of open fibers. Even a small area of open fibers like this is going to prevent the pressure climbing upstream from the oxygenator. So unless you can visualize somehow that you've got a full face of clot, you're not going to see the pressure jump. So you won't get that clue that you're looking for. Here we have a mountain of clot in the middle of the oxygenator. This is more of a nightmare situation in that you've got so much clot that's growing and shedding and flowing downstream into the patient's arterial cannula, and wide open sections of fiber around this that are not going to transmit any pressure increase upstream from the oxygenator. So other than a small change in color, perhaps in the center, you're not going to have any clue that there's a lot of clot growing. This makes sense when you look at the Spencer-Reed relationship. Across the bottom, you can see where the cross-sectional area decreases from 0 to 100%. And this is true whether or not you're looking at a coronary artery, 3/8" perfusion tubing, or the cross-section of an oxygenator. As the clot would grow, the blood would slowly decrease. But as you can see from the line, it's flat. The red line is flat all the way up to 60 or 70%, at what time it drops rapidly. Since pressure and flow are inversely related, this late phase would also provide quite a large jump in the pressure. So that's going to be the area where you're going to find out that there's clot, but it's going to be a late sign when you have a lot more clot than you're figuring. The fourth one is a dilution measurement, which is pioneered by Transcranial, where you have the meter connected to the arterial and venous side with flow sensors. A small room temperature saline bolus is made prior to the oxygenator, and as the saline bolus moves through the oxygenator, it is read by the arterial sensor, and it informs you how much volume is between those 2 points. Here you can see the injection being made into the line, and as the arterial bolus flows through the oxygenator and it reaches the arterial sensor, then the second flow wave is marked, and you can see the gap between those is the volume measured. So the line between the original spike and the red flow tracing shows you how much volume has been injected. So you know the volume between those 2 points. On the screen, you'll see the 2 spikes where you had a saline injection. Those 2 spikes will give you the oxygenator blood volume. It'll also trend over time. You'll see how they'll have the same volume, and it will decrease as the clot grows. Whether or not you can see it in the front, whether or not there's a pressure difference, you will see the shift in the volume. A fifth one has been looked at lately is the oxygenator CO2 output. There's a study done by Dr. Kessler in Aachen, Germany, who showed a bunch of expected results, but there was some unexpected ones. Dr. Kessler injected different amounts of silicone into different oxygenators. He used volumes of 30, 40, 50, 65, and 85 cc's. And in the bottom, you can see where he took those oxygenators and scanned them on CT to see how much clot was actually in the middle. Now, this won't perform exactly the same as blood clot because the silicone is more cohesive. It'll stay into more of a spherical shape, but the volumes would be the same. Here we'll take a closer look at the 65 cc volume. You can see the small amount in the face that would barely be visible if it was blood matching the color of blood. And there's a lot of wide open fiber, so you wouldn't see any difference in the pressure differential. However, in the middle, 65 cc's is 1/3 of a 215 cc oxygenator, and you can see a lot of clot inside on CT in the lower diagram. He ran flows through the oxygenator at 5, 2.5, and 0.5 liters per minute. And you can see from the graph, nothing changed drastically until after 65 cc's. It took off in the 5 liter per minute one. So the pressure would definitely reflect after 1/3 of its full. More troublingly, the lower graph at 0.5 liter flow, you have almost no change. So that oxygenator on a baby would have no change at all until much later than 1/3 of it being full. However, there was one result in his paper that wasn't really addressed very much, and that's the amount of CO2 leaving the oxygenator. In all 3 flow ranges, it was fairly linear and decreasing. Counterintuitively, you would think it would rise. But the point here is this might be another avenue where you might be able to measure clotting downstream. The 6th one we want to look at is a transcranial Doppler. There's a very gifted doctor that was at Cleveland Clinic, and he's been at Johns Hopkins for 2 years, Dr. Cho, who's been taking a look at the results of microembolic signals as they flow through the middle cerebral artery while patients are getting valves done, VADs, ventricular assist devices, and now he's taking a look at ECMO. Here is a patient's results that he had. One patient on ECMO, he was getting a lot of microembolic signals in the upper diagram, and once the oxygenator was changed, in the lower diagram you can see it's very clean. There's no embolic signals at all, implying that there was no clot flowing through the brain. This is going to have some very groundbreaking results if he can study this further and give us more insight onto how much clot is acceptable. So those are the basic things we're using now and hopefully will be using. To give us an idea, we have the flashlight test, the coagulation testing, pressure differential, and all that we now know about that. The dilution measurement that is available now, and the oxygenator CO2 output, time will tell. We don't know how that'll shape up. And the transcranial Doppler, which is taking care of the brain, which is something we're all looking at more and more. If you have any questions regarding any of this, reach out, let me know, or any of the sales reps or distributors, and we'll be glad to fill you in on anything you need. Thank you.